Hello, good day. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome everyone to our weekly webinar series entitled Medical Health Considerations of COVID-19. Today, we have a very important update on COVID-19 vaccine clinical trials, and that will be our main presentation. And that will be followed by an update from the front lines from Ethiopia. Next slide, please. I'd like to thank our webinar series partners for helping to support and to promote our webinar program. Next slide. This webinar will be recorded and placed on the ACMT webinar page website, www.acmt.net/COVID-19 web. The posting will be on Friday, and you'll receive a notification of when it's posted. We also have a series of webinar Q&As posted on the website, and any questions regarding this webinar series can be sent to us at webinars@acmt.net. Next slide. There will be a Q&A at the end of the webinar. So you can type your questions into the Q&A function during the webinar, or the chat function, on YouTube. But please, put in questions, and we like to try to get to as many as possible in the last 15 or 20 minutes of our webinar program. Next slide. At this point, I'd like to turn to my co-moderator, Dr. Ziad Kazi, who's a board member of the American College of Medical Toxicology and president of the Middle East and North Africa Clinical Toxicology Association, and associate professor at Emory University. And Dr. Kazi is going to provide a brief intro and introduce our speakers today. Thank you.
Thank you, Dr. Wax. Next slide, please. It's unbelievable that we are still at it, responding to this incredible pandemic for the past 10 months. At least though today, it's some optimism in the air with SARS-CoV-2 vaccines on the horizon. Next slide. Next slide, please. That said, we are still far from, going back to our old world or new world. And we have several issues that are still unresolved with the vaccine, for example. Specifically, vaccine acceptance by the public, the various populations of patients that will need the vaccine, how they will have access to it, would it be available in sufficient quantity, and how it will be distributed. Of course, we know there are a lot of vaccines that are currently under trial, clinical trials, various stages. So which ones will actually be ready for administration to the public? And what dose? Do we need a booster? Are they safe and efficacious? All of these questions remain unanswered as of today. Next slide. Next slide, please. In the meantime, I think Dr. Fauci really expressed it very well with his co-author in this recent article in JAMA, where he basically emphasized the need to still keep our guards up and practice our basic measures that are proven to be efficacious, such as hand washing, social distancing, and of course masks. But even in that area, there are a lot of questions that are unanswered, and there needs to be some additional effort in that direction. Next slide. Next slide, please. For example, with regards to masks and the importance of masking, we still are behind in the risk communication about transmission and the importance of masks. Dr. Fauci points out in his paper that there are no randomized controlled trials looking at masks and their efficacy. However, there are some observational studies, limited number of observational studies, that show that masks help, and we do need more research in this area. Having just 2 studies quoted by Dr. Fauci in this paper, one in which 124 Chinese households were found to have a lower odds of transmission of the infection if one or more of the household members were wearing a mask when someone in the household got infected. And the second study amongst healthcare providers in the US that showed that once the hospital instituted a masking policy on all patients and healthcare providers, there was a decrease in the infection rates amongst healthcare providers from 15 to 12%. These are good observational studies to support our recommendations for masking, but certainly we need more research in that area. Next slide. Additionally, I believe there's the lag in science and evidence regarding the transmission of this virus with aerosol versus droplet. I know we've been going back and forth between those two. I think it's critically important to for the scientists and the science to really resolve this this controversy or this incompletely studied question. Next slide. And finally, again, the $100 million question is, when are we gonna get the vaccines? Where are we now? And for that, I have no one better to ask to present on an update than Dr. Evan Anderson. Next slide. Dr. Evan Anderson is a professor of pediatrics and medicine at Emory University. He was our speaker in July on the vaccine topic, and he was kind enough to take time away from his extremely busy schedule, serving as the PI at Emory of the messenger RNA vaccine for SARS-CoV-2. Dr. Evan Anderson is going to present to us a candid perspective and an update on the various vaccines that are currently in trials, and will answer our questions. And I know there'll be many, so please remember to put them into the Q&A box, and we'll address as many as we can at the end of this webinar. Dr. Anderson?
Thank you so very much for the opportunity to talk with you and for the invitation to come back and to update you about where we're at with COVID-19 vaccine clinical trials. So, there we go. My financial conflicts and disclosures are as listed. Importantly, I serve as the local PI for the Moderna 1273 phase 1 and phase 3 studies, and also for the Janssen AdV5 spike protein vaccine study. I'd like to take just a minute and just remind you of a few critical things. So first is that the advent of SARS-CoV-2 is not the first coronavirus to arrive to cause problems for us. So for those of you that have been around for a little while, you remember the first SARS, which initially emerged in 2003. And then since that time, we've also seen the Middle Eastern respiratory syndrome due to MERS. The reason for that is partly because we as humans actually live in fairly close proximity to our animals. And the picture up in the upper left is was kind of made famous during the 2009 H1N1 pandemic or swine flu pandemic. You can see then this individual with a bat, and then this child with a camel. Of course, these are known animals to carry coronaviruses that we don't necessarily see circulating in people. And to the extent that we continue to interact with our animals, we will continue to see leaps across species. I think one of the very positive things that we can take away from the original SARS coronavirus outbreak back in 2003 and then MERS in 2015 is that there was a lot of basic science that was performed that actually really helped us to be much better prepared for SARS-CoV-2. And this paper from Barney Graham at NIH kind of highlights that fact. And what you see here is that this is against MERS, so the Middle Eastern Respiratory Syndrome. They actually looked in mice at use of mRNA vaccine. And in essence, it generated neutralizing antibodies. It decreased the amount of virus in the lung, prevented lung hemorrhage. And then in comparison to placebo, which is this gray line you see down here, it also prevented these mice from dying. And so these were data that had been generated, although not published prior to the advent of SARS-CoV-2. And so this basic science actually had gone a long way towards giving us some idea of what we needed to focus on, that being the spike protein, and that the idea of an mRNA vaccine or a vaccine in general against the spike protein could provide benefit. Of course, the spike protein for SARS-CoV-2 is a bit different than the other coronaviruses. And here you see the degree of homology between the other human coronaviruses, including the endemic ones, which are on the bottom right. It's this receptor binding domain that's kind of the key piece of the virus, we think, in general, for which an antibody response may provide, or an immune response against that may provide some benefit. I'd like to take a second and just thinking about things from a big picture standpoint. Of course, with SARS-CoV-2, it is that spike protein sticking off, which is the focus of the antibody, or the focus of many efforts to develop an immune response. If we think about other vaccines for which we have currently licensed products, there's several methods that we don't anticipate will be going forward anytime here in the US, at least not in the near future. For example, would be the live attenuated vaccines, such as live attenuated influenza vaccine, rotavirus, MMR, rubella, and varicella. We don't anticipate that there'll be any live attenuated vaccines with SARS-CoV-2. We also don't think that there'll be any inactivated vaccines, at least in the short term here in the US. And this is in part due to concerns about the possibility of developing an adverse response to the inactivated vaccines. Inactivated vaccines that include hepatitis A and the inactivated polio vaccine. The technologies that have been the focus have been the vectored vaccines. There's one that's currently licensed in Europe, which is the VSV backbone Ebola vaccine. And that would be one example as well. The AdV5 Ebola vaccine also is another example of a vectored vaccine in which you use a different virus to one to which it's thought that humans have minimal safety concerns, and then you insert a protein into that vaccine, or into that virus, that then serves as a vector to carry the protein in to cause an immune response. The classic protein-based vaccines such as PCV7, PCV13, Hib, hepatitis B, HPV, this technology has been kind of our standard technology for many years. However, this technology is a bit slower as far as the ability to develop a recombinant protein, and that's why we're seeing these lagging behind the other technologies. The other technology, which has been the primary focus for advanced vaccine candidates, is that of RNA technology. And so this is completely new technology in which the genetic sequence for the spike protein is inserted into typically a lipid nanoparticle that then is injected, and that mRNA carries the genetic sequence to make the spike protein from SARS-CoV-2. Many of you may have seen this slide, which is from Operation Warp Speed, which outlines the efforts to try and move forward a vaccine on a much faster timeline than would typically be feasible. So the goal was to be in 14 months or sooner. Typically, it's taken years for vaccines to move all the way from the lab to licensure. Notably, there are 44 currently in clinical trials around the world using a variety of technologies and 154 in preclinical evaluation. I will not be able to spend my time talking about all those vaccines because there would you'd be here for a very long time. I'm going to focus my discussions on those that are most likely to move forward here in the US, and briefly mention several others internationally. What had happened is that Operation Warp Speed, in essence, decided that to move forward at least one vaccine to actual licensure, they thought it was important to use multiple different technologies and multiple different vaccine manufacturers in case issues should develop between the initial phase 1 and phase 3 studies. So there were 2 mRNA vaccines that were chosen for to move forward to receive funding. That includes the Pfizer mRNA vaccine. Notably, they're up to over 42,000 out of their planned 44,000 enrollment, with over 35,000 receiving a second dose of vaccine. The Moderna mRNA vaccine then entered clinical trials, phase 3 clinical trials at the same time. They've completed the 30,000 that they plan to enroll, with over 25,000 receiving a second dose. The two viral vectored vaccines, AstraZeneca, the chimp spike vaccine, had been on hold until just this past Friday due to concerns, and we'll mention those later. And then also the Janssen AdV5 spike protein had also been on hold for just a couple weeks. Then there are two S protein-based vaccines, one from Novavax, for which there's some published data, and then Sanofi and GSK, for which there's not available data currently. Notably, this effort is all to develop a vaccine for adults. This does not include pregnant women or children for that matter. And so that's an issue that I think, certainly we can explore if we have additional time. So just to briefly outline, here is the overall phases of clinical trial development, initially starting in animals and then moving into phase 1, phase 2, phase 3 studies. As you go up, you can see the numbers of individuals increase. The dose gets established in between phase 1 and phase 2 and the timing. And then in phase 3, we look at safety for fairly uncommon but not rare side effects, and then efficacy. How well does it actually work in terms of preventing disease? Notably, the trials that are being conducted, say with a number of participants in the range of 30,000, 15,000 of which will receive vaccine, still will not be able to appreciate a 1 in 10,000 increased risk of a safety event. And you can see here there's the 4 that are currently in phase 3 clinical trials, and then the other 2 in phase 2 currently. One thing I'd like to highlight, and this is an important kind of distinction, is that, that in general we need immunogenicity, meaning an immune response to the vaccine. Safety of a vaccine does not necessarily equal reactogenicity. And this is a key point. Reactogenicity are things that we kind of expect to see with the vaccine, both local and systemic side effects from receiving the vaccine. These are typically due to the turning on of the innate immune system by whatever the vaccine is. And so this includes local symptoms like pain, redness, swelling, tenderness, soreness at the site of injection. Also includes the systemic side effects of fevers, chills, achiness, myalgias in the day or days after receiving vaccine. We expect to see these. These are quote unquote getting the quote unquote flu after the flu vaccine, or for those of you that have seen or cared for patients that have received Shingrix, for example, the reactogenicity with that vaccine is actually pretty substantial, where a lot of people feel pretty miserable in the day or a few days after they receive the vaccine. Safety is usually separate, but can overlap with reactogenicity. Safety includes lab or organ toxicity, serious adverse events, meaning hospitalizations. The examples of safety events would include Guillain-Barré syndrome that was seen after the 1976 swine influenza vaccine. Another example would be if one of the vaccines were to result in increased severity of COVID-19 disease rather than decreasing severity or preventing disease. That would be a safety issue that one would want to identify ideally before licensure. There can be some overlap between safety and reactogenicity. Where we see that most commonly, there are classic examples would be febrile seizures in children in association with certain pediatric vaccines. In one participant in the Moderna phase 1 study had pre-syncope due to reactogenicity at the highest dose of the vaccine. So they can overlap, but they don't necessarily overlap. In general, the philosophical approach has been to minimize reactogenicity, but a safe vaccine can actually have substantial reactogenicity. Again, the classic example being Shingrix. And actually, our reactogenic vaccines can have a better immunologic response and maybe even better at preventing disease. For example, whole cell pertussis versus acellular pertussis, and as well the Shingrix vaccine again. Safety is always critical for our vaccines as they're given to otherwise healthy people. And once you administer a vaccine, you can't take it back. And so, especially for the phase 1 studies and the early studies, they start slowly with a small number of sentinel subjects, frequent pauses in enrollment, small numbers are enrolled and doses slowly escalated. I'd like to take a few minutes and then highlight the key features of the vaccines and like to just highlight some of these, try and give you the big take takeaway pictures as far as the classes of vaccines and their side effects. So for the mRNA vaccine, that's Moderna's vaccine, what we saw is that with increasing dose of vaccine, we saw increasing severity. And this is first dose versus second dose. And here you can see systemic symptoms and then local symptoms, with the orange being most severe. And in essence, with the second dose, we see more severe reactogenicity. And then with increasing dose, higher reactogenicity. Most symptoms were local pain, and then from a systemic standpoint, chills, headache, myalgias, nausea, and fatigue. You know, this wasn't directly compared to flu vaccine, but in comparison to most flu vaccine trials, it's probably a greater reactogenicity than you'd see for your usual flu vaccine. From an immunogenicity standpoint, this is a key question, is how well does the immune response get stimulated? So 2 doses of vaccine. With increasing dose, we saw increasing immune responses. If you take any of the 4 different panels here, in essence, with increasing dose, you see increasing response, but you do see some flattening between the 100 microgram dose and the 250 microgram dose. And then because of safety concerns, the decision was made to move forward with the 100 microgram dose as being thought to be sufficient to generate a good immune response. In comparison, on the far right is the convalescent plasma from those that have previously been infected with SARS-CoV-2. And of course, that's not standardized, so it's very variable from study to study from that standpoint. And what you can see is key things is that you see both binding antibodies, which are panels A and panels B, pseudo-neutralizing and neutralizing antibodies are both produced as soon as 7 days after the second dose of the vaccine. This was also, we also published data about the older group of individuals, so 56 and above. And in essence, the data was very similar to the young adults, meaning those less than or equal to 55. Again, some severe events with systemic severe events occurring occasionally. Fortunately, the immunogenicity was preserved with in these older adults, which is not necessarily something that we expect to see. As many of you are aware, for a seasonal flu vaccine, we go up to high dose seasonal flu vaccine in order to improve immune responses. Here, immune responses in a small number of individuals seem similar between kind of the young adults, which are the group represented right here, and then those that are 56 to 70 and then 71 plus years of age, both in terms of binding antibodies, pseudo-neutralizing antibodies, this which is a form of neutralizing antibodies, and then also classic neutralizing antibodies. Responses were fairly similar, maybe a slight decrease in those at 71 plus years of age. Again, there's not a current correlative protection, but the responses were similar to convalescent sera and similar to young adults. So if we go on to the next slide, this is then data for the Pfizer vaccine that was just published recently. And again, big picture things are that there are 3 different doses represented. And what you can see is that for the Pfizer vaccine, again, you tend to see a little more reactogenicity with the second dose than with the first dose. And most of these are mild to moderate in severity. And in the older adults, perhaps there's a trend towards less reactogenicity than in the younger adults. Although I think it's not, that still remains to be completely verified. Local symptoms tend to be pain. Systemic symptoms of chills and fatigue are most common. Safety was fine for this vaccine. And here in this figure, which I kind of compressed down to make it a little easier to see the data, in essence, with their vaccine that they're moving forward with in their phase 3 clinical trial, again, doses at days 1 and 21. With increasing dose, they saw increasing response, and they're going with that 30 microgram dose. They saw both binding and neutralizing antibodies, rapid increase by 7 days after the boost in terms of those binding and neutralizing antibodies, and there's no current correlative protection, but similar to or better than convalescent sera in terms of the immune responses. So this briefly just summarizes key features of the mRNA vaccines, typically increasing reactogenicity with the second dose and also with increasing doses. The immunogenicity is dose-related, and we see this rapid increase by 7 days after the boost for both vaccines, and results in similar antibody levels to that of convalescent plasma. Switching over then to the viral vectored vaccines, so the chimp adeno spike protein vaccine, which is the AstraZeneca vaccine, reactions were mostly mild to moderate. First dose is on the top, second dose is on the bottom. And you see that actually the reactogenicity is worse with the first dose than the second dose. So this is different than the mRNA vaccines. A number of people actually received paracetamol, which is Tylenol, in this study because of anticipated reactions. From the local symptom standpoint, they saw pain and tenderness. From the systemic standpoint, they had fevers, chills, headache, myalgias, and muscle ache, including some severe events, or moderate. Essentially, they're all moderate events at most severity. For their immunogenicity, then, they had been hoping that they would see just a single dose as being sufficient from the immune response. And here you can see binding antibodies on the top in panel A. In comparison to convalescent plasma, it was not nearly as good as they had hoped. And so they actually have moved forward with the 2-dose schedule, the prime boost dosing, which puts the immune responses into the range of those observed with convalescent plasma, both in terms of binding antibodies and then on the bottom, neutralizing, a form of neutralizing antibodies. Importantly, before I completely leave that topic, they had the safety hold. And so this was a long safety hold that happened beginning in early September until just this past Friday due to suspected adverse events associated with the vaccine. For the Janssen study, there's a manuscript and pre-published from that standpoint. Just highlight what we do know. The data is much more limited here, but 72% had reported solicited AEs. And so this is the Janssen AdV5 vectored vaccine. 58% had local symptoms. A few of these had grade 3 pain and tenderness, particularly injection site pain. Solicited systemic events in 64%. Again, 11% had severe grade 3 side effects, with most frequently being headache, fatigue, and myalgia. Fever is reported in almost 20% of patients with grade 3 and 5%. So certainly we do see some grade 3 events with this vaccine. In terms of the immune response, a couple key things here is that they actually saw reasonable immune responses in the 5 × 10⁻⁻⁻ dose. And so they didn't go up to the 1 × 10⁻¹⁻ dose for their phase 3 clinical trial, since the immune responses were fairly similar between the 2 doses. And so the reactogenicity is a little better with that lower dose. And that's why they decided to go forward with that. Again, they saw binding and neutralizing antibodies. The other key thing is that it was up into the range of their convalescent plasma with a single dose. And so they decided to go forward with the single dose of vaccine. Of course, we don't really know what the correlate of protection will be, so we don't know whether 1 dose will be sufficient or not. But I think many people are hopeful that this could end up being a single dose of vaccine. They did have a safety pause. And again, their study had also reopened on the 23rd of October. So both of these are restarting slowly in their phase 3 due to the study halt or pause. For the AstraZeneca, number of people did receive Tylenol just routinely. Reactogenicity was worse with the first dose than the second dose. So a rapid increase in terms of antibodies 7 days after the boost. For the Janssen study, reactogenicity is not quite as well spelled out, but single dose is all that's going to be needed. And they think that the immunogenicity appears to be similar to that of convalescent plasma with a single dose. Then moving on to the protein vaccines, there's 2 that are in clinical trials, one of which there's data, and that's for the Novavax vaccine. They're using the 5 × 5 with the matrix protein. So the matrix protein is an adjuvant that increases the immune responses. And in essence, you can see that middle row in general, we see slightly worse symptoms with the second dose than with the first dose. With pain and tenderness in particular being most common, and then systemic symptoms of headache, fatigue, myalgias, and malaise. And those were the key takeaway points from a reactogenicity standpoint. From immunogenicity standpoint, so this was a 2-dose vaccine at days 1 and 21. Again, with that matrix protein, or matrix M, which is designed to stimulate the immune responses. In terms of both binding antibodies, which are on the top in panel A, and then also neutralizing antibodies in panel B, these were similar to, or maybe even better than convalescent plasma, at least the convalescent plasma used in their study. So that's a positive thing. And similar to the other vaccines for which there's data, they saw primarily a Th1 biased response. The GSK and Sanofi data are at this point pending as far as I'm aware. So this summarizes the protein-based vaccines. So a number of you will have heard that there are other vaccines being used around the world. One of which is the AdV5 vectored vaccine from China. This actually, if you look at the binding and the neutralizing antibody responses, these are a little more modest as far as the immune response, in particular for neutralizing antibodies in comparison to what's been seen, where we saw essentially 100% seroconversion with neutralizing antibodies for all the other vaccines. So it's unlikely that that this AdV5 vectored vaccine will go forward in the US, in part because there's a lot of baseline immunity to AdV5 in the US population. For the Russian vaccine, that's actually a combination between 2 different vaccines, one of which is AdV5 and the other is AdV26. So this panel here is AdV5 alone, here is AdV26 alone, and you can see in comparison to convalescent sera, it was all right, but they actually saw better with a mix and match approach between AdV5 and AdV26 as far as the overall immune response. These data are now published, which is a positive thing from their phase 1/2 study. Their phase 3 study is ongoing, but they have, I understand, licensed it in Russia, despite not having phase 3 data. So will this concept work? Well, it's a key question, and I think we can, at this point, be optimistic that it will. There's a couple papers now that look at essentially immunizing macaques and then challenging them with SARS-CoV-2. And in essence, you can see that with receiving vaccine in comparison to PBS, which is the placebo, it decreases the amount of RNA in the BAL fluid and also in nasal swabs. So this gives us some hope that it may actually decrease risk of transmission as well. For a different vaccine, and this is the AdV26 vectored vaccine, on the far right here, you can see that in essence, it also decreases the amount of virus in BAL fluid and also in nasal swabs as well. So this gives tremendous hope that this concept may actually be successful, although at the end of the day, we need to prove that this is the case in humans. So a couple more slides before I finish up here. So many people question, what's the prognosis for timing? So Tony Fauci in ID Week talk on the 21st of October said mid-November to the beginning of December, and I can't do better than that. Previously, he'd said to CNN, could it be earlier? Sure. He thought it was unlikely, but not impossible. I think really we're looking mid-November to beginning of December based off of his most recent comments. There had been this concern that the FDA can allow unapproved medical products or to be used to diagnose, treat, or prevent severe life-threatening diseases, in part due to biological threats. Multiple manufacturers, in essence, got together and said, we're not interested in getting an EUA without actual safety and immunogenicity data. What has subsequently been clarified in new guidance from the FDA to industry is that they would like to see a median follow-up of duration of at least 2 months after completion of the full vaccine regimen. So that means at least 2 months for the 50th percentile individual, which for the vaccines, we can tell from data that they've released, would be probably at least mid-November or later. As well, they want to make sure that there's not increased risk of vaccine-enhanced disease as another key factor that they're also looking at. All the studies have halting or pausing rules, and these are put in place to protect participants that are involved with the study. For the AstraZeneca study, we saw this come into play with the episode of transverse myelitis. Janssen event is not publicly available at this time as to what that event was. They're also looking for any evidence of disproportional severity of COVID-19 infections in those that receive vaccine. There's a DSMB group, which is a group of independent experts that review the safety and efficacy data on an ongoing basis. They're able to review unblinded data, and there was a death in the AstraZeneca trial in Brazil that could be reviewed unblinded. They have ability to recommend to change the study, to terminate the study, or to even send the data on to the manufacturer for consideration for submission to the FDA as an EUA. Other factors involved with the timing of an efficacy answer, and this is a key point. So safety, we're looking kind of mid to late November for that minimum of 2 months before the FDA would consider an EUA. Larry Corey from the CoVPN had said, well, do the math, and that was a publicly quoted quote. So the question for many people is, well, how do you do the math? Well, the math kind of depends on the following factors. So first is, does a vaccine require 1 versus 2 doses to see an effect? For most of them, we anticipate 2 doses, with the one possible exception being the Janssen study. Second is the number of participants enrolled. For all the trials, they're looking at 30,000 or more. As you heard, Pfizer's gone up to 44,000 and Janssen's actually going to do 60,000. So bigger trials will have more endpoints resulting in faster answers. Third is the incidence in the population enrolled. So of course, we had a relative trough of cases in the late summer, early fall, but now we're seeing an explosion of cases kind of throughout the country. And so as such, that will generate more data as participants in the study get exposed to SARS-CoV-2 in the midst of their daily lives. Fourth factor is, when did the study start and when is it expected to, or when does it complete? So of course, those studies that started back in end of July, which are the mRNA vaccines, have a big head start over the other vaccines at this point in time, since both AstraZeneca and also the Janssen vaccines are at this point just restarting their phase 3, and the other 2 protein-based vaccines are looking either later November or December. It's kind of unclear when their timeline is for starting. Final key question is, how well does the vaccine work? And so what is the case is that there's planned time periods where, and these data are publicly available. You can Google their protocols actually. And so they specify in that where they're planning on analyzing the data for efficacy. And so Pfizer's pre-specified at these numbers, Moderna's pre-specified at these numbers, is when they'll take a total number of cases of COVID-19. They'll then take a look at the data, or the DSMB will take a look at the data. So if we use just a round number of 100, for example, if there were 95 in placebo and 5 in the vaccine, then assuming that the safety is good, this is a highly statistically significant difference. And so this would immediately trigger efficacy endpoint. This is not a statistical fluke, but this is real efficacy. If, however, the vaccine has a more modest effect, and say there were 60 cases in the placebo group and only 40 in the vaccine, then that's not a statistically significant difference, and you're going to continue on from this X time period, which say was initially 100 cases, up to here, which was say 150 cases, for example, in order to identify whether or not there's a difference. So other vaccines are being developed worldwide. This is good, and we actually need this. There won't be enough capacity to provide enough supply for the entire world. It's uncertain which, if any, of these will be tested in the US. Data in non-human primates looks good for vaccines focusing on the spike protein. An EUA could be issued by the FDA, but it's unlikely to happen that they'd issue an EUA without kind of meeting this minimum guidance from the FDA, meaning 2 months median follow-up, which is probably mid to late November based off of what we anticipate, based off of numbers that the vaccine manufacturers have released publicly. And then the key question is the number of actual cases of COVID-19 in those receiving vaccine versus placebo in the midst of their daily lives. And then that is critically dependent upon how well the vaccine works. So if the vaccine works 95% or 90%, that's going to result in a faster answer than if it works 50% as far as efficacy. So we are having ongoing searching for a vaccine. We've got a ways to go, but we've made tremendous progress, and I think we've are in much better shape here in late October than we were back even a few months ago. And I'll break there.
Thank you so much, Dr. Anderson. This was a enlightening presentation. We appreciate your candid discussion of all of this information, and I'm sure that our participants feel much better now that they understand more about what is going on. We have a huge number of questions, so just stay tuned. We are going to move to the update on the front lines, which was actually recorded because of the technical difficulties we encountered last time we were trying to do it live. Our next speaker is Dr. Sofia Kebede, an assistant professor in the Department of Emergency Medicine and a medical toxicologist at the College of Health Sciences School of Medicine, Addis Ababa University, Addis Ababa, Ethiopia. She's going to give us an update about COVID-19 in Ethiopia. She will try to join us online for the Q&A if the technology allows it. Otherwise, we can copy the questions and send them to her by email and get you an answer. If you can please play the recording. In the meantime, continue to send in your questions on the Q&A, and Dr. Wax and I will address them at the end.
So, hello everyone. My name is Sofia Kebede. I'm an emergency physician from Ethiopia. I work at the College of Health Science, School of Medicine, and Addis Ababa University. I'm an assistant professor there. Today, I'm going to speak a little bit about experiences of COVID management in our country. Next slide. So if you're wondering where Ethiopia is located in the Horn of Africa, bordered by Kenya, Somalia, Djibouti, and Eritrea, and Sudan. We have a population of more than 100 million people. Maybe Ethiopia is famous so to be one of the free countries not colonized. That's what history tells about Ethiopia. So today we'll see a little bit about what this pandemic COVID brought to our country. Next slide. So as of today, October 19, these are the total number of patients infected with COVID-19 in our country, 89,000 confirmed cases with 1,252 deaths. So this number would likely change in the coming few days when the presentation will be on. We also have around 40,000 people who have been declared cured from COVID and who went back home after being treated in different treatment centers. So you can see the graph as the numbers were spiking, especially in August and September. There was a high peak, but now it's coming down, it's gone up. And there are also a lot of factors about the numbers that you see here. Our screening methods, the number of tests that we're doing each day are not consistent. So till now we have screened around 1.4 million people from all over the regions in Ethiopia. So from 100 million, that's really a low number. And we predict that if we have the capacity to screen more people every day and to increase our capacity in testing patients, these numbers will likely be higher than what we are seeing every day here on the map, on the graph. Next slide. To say a little bit about COVID in our setup, we had our first cases around mid-March. Um, Even before that, after China's, the Italians and the Americas experience, our government was trying to prepare COVID centers in anticipation of this virus, because as WHO declared it a pandemic, we knew it was only about a matter of time before we get our new cases. So what I meant here by COVID centers is that some hospitals were completely evacuated just to give treatment for COVID suspects as well as COVID confirmed patients. When the government thought that would not be enough, they also tried to recruit other halls, larger halls that were not health facility, to accommodate the then expected large number of COVID patients. Along with the preparation of the centers, there was also started the preparation of human resource. Training was being given on how to manage this new virus, the COVID cases. Also, labs were also being prepared to uh, screen patients, take samples, and confirm the existence of the virus. Uh, because before the COVID pandemic, our labs were not really doing the PCR tests on different viruses. And with the emergence of this virus, most of the labs started to do the PCR test that is thought to be the gold standard to detect the virus in the human sample. So there were a lot of screening methods that were being taken by then. As it was a pandemic and we had 0 cases by the time in our country, so we thought the entry would be from other countries. So people coming, especially from China, Bangladesh, and then Italy, those countries with high number of cases by then, people were being screened as they entered the country. And then this screening method was being enlarged to include patients with travel history in the past 2-3 weeks, with some symptoms of cough and fever, and the screening got larger and larger and larger. And after a couple of months, the screening started including patients even with no travel history, as we know that the virus was already disseminated in our society. So after a couple of months, other countries were doing taking experience from other countries. Different lockdown methods were instituted. It was very difficult. Schools were all shut down. Our airlines were also shut down. There were almost no flights. Some people were told to work from home. Some of us were also working actively in the hospitals and also giving trainings, but everyone was scared and everyone was trying to keep social distancing, started these hygiene methods and everything. The lockdown was not really persistent, especially with our population having a lot of economic problems and burdens, and people staying at home, not earning anything, not earning their income daily was very difficult. And then after a couple of months, the government was loose, and then some offices, some people started going about their own business, but still schools were closed for the last 7-8 months now. And as of today, Monday, some schools are starting reopening with due precaution. And at the era of the lockdown, the other thing that I forgot to mention was universal mask usage was started by everyone and everywhere, in school, in buses, and on the road, in the train. Whenever people were leaving their homes, they were supposed to wear masks, which was good. And then, as I said, after 7 months, we're starting to reopen schools this week. But the Ministry of Health has said that we may see a resurgence of new cases now with the opening of the schools, or we may not. So we're just waiting to see what the picture will look like. Next slide. So as a developing country, there were a lot of challenges to deal with the pandemic. As soon as it was declared a pandemic, we started gathering lots of materials from other countries, like the screening tools, the screening kits, also materials needed to care for patients, the oxygen cylinders, the ventilators, everything. Most of the things were supposed to be imported, and with the flights being cut down was very difficult. There was a lot of resource constraints. I'm sure this is not peculiar to our country. We have heard the experiences of different nations. Resource constraints were major. Human resource, especially in our country where we don't have a balanced number of health professional to population ratios. Also, at a certain time, even beds in the COVID centers were all occupied. ICU beds were full, and then there was a little bit of overflow of patients seen. And then by the time COVID centers were overloaded, the government tried to recruit other hospitals and other centers. They also started to see if we can treat asymptomatic and mild cases of COVID at home, so that the burden on the centers could be alleviated. Human resource development, that's also the very area that we had problem with. A lot of training was being given to health professionals who were working directly in the front zone with consultants like us, and also to screen patients from the society and everything. So as this were a lot of challenges, there were also a lot of solutions that were being tried to put in place with every problem identified. In resource constraints, there were also a lot of problems about the drugs that were being used with COVID. At certain time, people were saying we have to use chloroquine, and then there comes the dexamethasone, and then the antivirals. Some of the drugs like dexamethasone, chloroquine, we have in abundance, but the antivirals that are being used are not available in our country. So even if we know their best experiences say we should use for patients, we're not really using them. So the last challenge was post-COVID care. These patients, after they were declared cured from the centers and sent back to the community, they would be told to isolate themselves for a few days, to look for any emerging symptoms like fever, cough in themselves as well in their close contacts at home. And then especially the ones who had moderate and severe illness, they're supposed to have a sort of follow-up with their primary care physicians. But since the pool of COVID patients were from different areas, it was really difficult to challenge them into one hospital or clinic that can give them a consistent post-COVID follow-up or care. But still, there are trials where trying to see patients, and we're also identifying things in their, symptoms in their lung functions, in their x-rays and everything that show residual COVID complications. But still, we're trying to enroll all cured cases on the follow-up, and then for those who have normal symptoms, normal outcomes or no symptoms, at least after a couple of visits with the doctor, they can be advised on how to continue their precautions, and they can be set out to the public to continue their normal activities. So this is all I have. Thank you so much. If you have any questions or comments, you're welcome. So hello, everyone.
Thank you, Dr. Kebede, for this important update from Ethiopia. You raised some important points and lessons learned. Now we are going to turn it over to the questions and answer session. We may actually go about 5 minutes to 10 minutes after 4 p.m. Eastern, just to cover the number of questions we have. Before I turn it over to Dr. Paul Wax, Dr. Anderson, I have a question for you. In your interpretation of the data and the EUA and the follow-up period of 2 months required, are you saying that you think the EUA will be released based on your interpretation of the data about mid-November? And if so, when did that 2 months period start? Are we assuming it started in mid-September, as far as the clock ticking for that 2 months period? Just want to clarify that, please. I think you're on mute.
Yep. So it's obviously a little bit confusing to people, and I hope I didn't confuse things further. The FDA said that it would need at least a minimum of 2 months after that, after the kind of midpoint person receives vaccine. So for a 30,000 person trial, that means the 15,000 person has to get 2 doses of vaccine or placebo, and then to be followed for 2 months after that. Now, both Pfizer and Moderna have released their enrollment numbers and the numbers that have received second doses of vaccine. As a rough estimate, that's looking probably mid to late November based off of the data that they've released. So that's the safety piece. The efficacy piece depends upon those total number of cases of COVID-19 that have happened. I think most people anticipate that the FDA will want to see actual efficacy data, and that will depend upon that complicated math equation. And I think Tony Fauci is probably the best person to comment on that. And he'd said again, mid-November to December in his most recent talk.
And have we had any of the vaccines look at doing an interim analysis yet on efficacy, or has that not been done yet?
It's a great question. I wish I knew. Neither vaccine manufacturer that would be in a position to potentially have that data has released anything publicly, so I have no idea. I think Dr. Fauci's estimations probably based off of data that he's aware of that the rest of us don't know.
Okay, thank you, Dr. Anderson. I'm going to turn it over to Dr. Wax to start with some of the Q&A.
Okay, thank you very much. And thank you, Dr. Anderson, for really a superb and timely presentation. Just a word to the folks that are still watching. Dr. Anderson did start to answer some of the questions in the Q&A during the last presentation. So I refer you to the Q&A for his responses to those questions. So my initial question is about the concerns of the vaccine efficacy in the old and the very old. These are some of the most vulnerable population, those in their 80s and 90s. Many of those have been basically in isolation now for many, many months pending a vaccine. Would we expect the vaccine to be equally efficacious in that group, or is there a loss of immunogenicity in the old that might actually prevent them from being safe with a vaccine?
Yeah, it's a great question. So both the Pfizer and the Moderna studies both have released data in those into the well above age 65. From that standpoint, these were phase 1 data, and so they were typically healthy older adults with stable comorbidities. As such, will that apply to the whole population? Probably not. But the available data do suggest that the immune response still looks fairly similar to the younger adults, which is good news. I think that there is a fair amount of concern, particularly for our most chronically ill and fragile patients, such as, say, long-term care facility inhabitants, nursing home patients, that it may not work as well in that setting. And so there are active ongoing studies of long-acting monoclonals for prevention of SARS-CoV-2 in those populations. And a lot of that data is ongoing.
Okay, great, thank you. So a question that came in over the YouTube simulcast from one of our listeners, who said he preferred not to take the vaccine. He said he was young and healthy and would prefer not to be exposed to medicine. And he's asking, is this wrong, basically? Yeah,
so if that participant is young and healthy, I can tell you it's going to be a while before you're going to be able to even receive a vaccine. So that's the first piece of information. If you're young, healthy, aren't a healthcare provider, it's probably going to be some months before you'll even be able to receive it based off of prioritization schemes that are being developed currently by a number of different groups. As such, the amount of data that will be available by then will be substantially more than is currently available for the vaccines, and even at the time an EUA is potentially released. So I think that we'll know a lot more about the safety by the time you're even eligible to receive a vaccine, and hopefully you'll change your mind once you're able to see the data.
Okay, great, thank you. So a question about the natural infection and levels of antibody drop-off after a few months post-infection. Have you seen a similar problem with maintaining antibody levels in the trials? And is anyone pursuing a different approach, a CD8 T cell based vaccine?
Yeah, good question. So we don't know what the correlate of protection is for SARS-CoV-2. And that's a key thing that many people are investigating and will hopefully come out in the midst of the vaccine clinical trials and will give us a better idea about the durability if we can establish some cutoff value, either in terms of a neutralizing antibody response or a binding antibody response that can give us some idea. There are, for essentially all the vaccine clinical trials, there are longer term time points that are being, blood is being drawn. So we'll have a better idea from those phase 1 studies, even over the course of the next few months, I think, about the durability of the immune response in comparison to the initial antibodies that were achieved.
Thank you. And how about healthcare providers or other folks that have already contracted the COVID-19? How will they be prioritized, you think, in terms of receiving the vaccine?
Yeah, for those that are previously infected, it's going to be a little complicated, and we in essence, we don't know how ACIP will end up kind of recommending things from that standpoint. So there will hopefully be additional guidance for those that have been previously infected. As part of the phase 3 clinical trials, the baseline immunity is being checked in the laboratory, and yet those that are have antibodies are not being excluded from the trial. So we actually will have safety and immunogenicity data in those that have evidence of prior COVID infection. So that will help to provide some guidance for those that are having to make that decision. But there'll be a lot more on that to follow, I'm sure.
Okay, great, thank you. A question about spike protein mutations and vaccine efficacy. Could you just address that in general and maybe compare that to our knowledge about other vaccines as they've mutated, other viruses as they've mutated?
Yeah, so of course, people are very aware of influenza and its tendency to mutate and accumulate a number of mutations which make vaccines ineffective over the course of time. From that standpoint, we're not seeing a huge amount of drift in terms of the spike protein. Yes, there have been some important mutations that have been identified. Importantly, the 614D to G mutation, which has become predominant in the population. The good news is, and we published this actually in the older adult manuscript with the Moderna vaccine, is that that mutation does not weaken the vaccine response. And if anything, the vaccine response or the antibody response is a little bit better with that mutation in comparison to, at least in the laboratory, in comparison to the original strain. That will continue to be a very active area of investigation because it could be that we would need to adjust vaccine over the course of time. I think the one positive piece is that if an mRNA vaccine or particularly if the mRNA vaccine was successful, it's very easy to make a change of the vaccine itself. That would, again, require some testing of immunogenicity and safety, but it's very, very easy to make a quick change in terms of the sequence.
Okay, great. Thank you. We've heard a lot about herd immunity, and I guess the question is, will everyone need to take this vaccine despite the developing herd immunity? You've addressed this in part in your prior question about people who were previously infected, but would you like to just address that particular issue, please?
Yeah. So the topic of herd immunity is one in which at a certain percentage of the population either having been infected or having received a vaccine, you can, in essence, it becomes very hard for sustained transmission of the virus to continue because it's not able to identify, when a single person becomes infected, they don't necessarily transmit to another individual. The challenge is that our population is a bit heterogeneous, and so particularly like nursing home settings and other settings where the vaccine may not work as well. We simply don't know. It may be that a single introduction into nursing home could still result in pretty extensive disease. The other key groups that I think a number of us have concerns about include our pregnant women, and then as well our children, where if there's not a vaccine available for them, the problem will be that these will serve as big reservoirs of ongoing infection that then can leap out into unvaccinated and undervaccinated populations.
Okay, great, thank you. The question about challenge trials, some of these are now conducted in the UK and elsewhere. How much time does that process potentially save from the vaccine efficacy evaluation process?
A challenge study is a study in which, to provide the background, typically young healthy adults without underlying comorbidities are given either wild type virus or an attenuated form of the virus. Now, we've not identified a great candidate for an attenuated virus that could mimic disease, but have less risk of side effects and complications. There are active efforts to try and do that. What the concept is here is that you, once you identify the correct dose of a challenge strain, you then would vaccinate some people and give others placebo, and then actually challenge them with the dose that's established. And then look at rates of disease in those that receive vaccine versus those that receive placebo. From that standpoint, it can give you an idea about how well the vaccine works in that population, which is typically going to be young, healthy adults, so the only ones that are going to be eligible for a challenge study. You still have to establish safety, and that meaning that you still would need to do large studies of thousands of people, potentially 30,000 people as well, in order to establish safety in large numbers of people. So this approach has been used for other vaccines. The best example in the recent past is actually the licensure of a cholera vaccine here in the US that used this approach of a challenge study. It's not going to be relevant, I think, for our vaccines that are furthest along, the viral vectored and the mRNA vaccines. It could become more relevant, particularly for any vaccines after the 6 that I kind of highlighted. It will become increasingly difficult to do studies here in the US and worldwide once you have a licensed vaccine.
Okay, great. And just a couple of final questions. One is about if someone takes the vaccine and then a subsequent vaccine is proven to be more efficacious, what will be the role for taking the second vaccine on top of the first vaccine?
Yeah, great questions. That's a question for which we don't have good answers at the moment. I would anticipate that there would be guidance from ACIP and other groups that are making advisory recommendations about this type of setting. And like many things with COVID-19, my answer here would even potentially change in a few months because we just, there's so much that's still unknown.
Following up on that, Dr. Anderson, sorry, Paul, I just want to ask a quick follow-up on this. With the ACIP, which is the, I think the immunization advisory group for this type of vaccine, new vaccines, would they add to the timeline before we administer the vaccine, or would that be in parallel with after an EUA? Would they add, because they're going to require several weeks probably to come up with their guidelines, correct?
Yeah, so good question. So, so that is the advisory group for those that are not familiar with the terminology that kind of sets vaccine policy here in the U.S. And they can make recommendations that extend beyond the scope of what's actually in the package insert that comes from FDA licensure. And they can be very helpful as providing kind of expert guidance and expert opinion of how to manage these challenging real life questions that are going to exist for these vaccines for the foreseeable future. They have ongoing discussions related to COVID-19. There's an ongoing working group that exists. They're actually having, as part of the ACIP meeting here in October, this Friday, they're having essentially a full day, I believe, of discussions related to COVID-19. So they are absolutely being kept apprised, and I don't think that their timeline's going to slow down kind of the rollout of initial vaccine, but they will be critically important in terms of deciding what those priority groups are for first receipt of vaccine.
Thank you. Back at you, Paul.
And my final question, again, is about timeline as well. As we've learned so much during this pandemic over the last 10 months, and there's so much we still don't know. Disseminating this vaccine, once we have a vaccine that's both efficacious and safe, will be an extraordinary burden as well. Realistically, where do we have to get to in terms of protection so we can revert back to where we were in 2019 as a society? And when is, and I realize no one has the crystal ball here, but when is a reasonable period of time to expect that we will be returning back to so-called normal?
Yeah, it's a great question. So part of this will depend upon how many vaccines actually end up getting licensed and the timeline for those licensures. So if we've got just a single vaccine available, the timeline's going to be much slower because in essence, the single manufacturer is not going to be able to make enough doses for the 350 million people here in the US. For most of the vaccines, that's 700 million doses of vaccine to vaccinate everybody here in the US. And that's just going to take a long time. So if there are multiple vaccines licensed, which would be absolutely my hope, that could shorten down timelines. I think it's going to be, and Tony Fauci said something similar, it's likely to be summer before we, next summer before we see kind of widespread availability of vaccine, and then a while before people can get vaccinated that would like to get vaccinated. So, and then we're going to be marching right up into the next winter respiratory viral season with probably not the entire population vaccinated. And there's a lot of concern about whether a number of people will refuse vaccine or delay their receipt of vaccine until there's more data. As such, I think it's likely that we're going to face some degree of lifestyle impact going into next winter respiratory viral season, and potentially sometime late, next winter to spring, we might see some real loosening in terms of recommendations. I think some things are probably gone for the foreseeable future, things like handshakes in particular. I don't see that coming back anytime soon, but and I think we will see some loosening as far as outdoor sporting events, potentially sooner, whereas your indoor sporting events and indoor concerts, choir related things, those could well be longer timelines.
Yeah, and let me just throw out two other examples. Medical or conferences, large conferences, and also seeing grandparents.
Yeah, so looking into the crystal ball, which is always the challenging thing. So I wish I could give you a great answer on that. I think that medical professionals will be among those, those that are caring for patients with potential COVID-19 will be among those to receive vaccine relatively early. So I do anticipate that uptake will be fairly fast in healthcare professionals. As such, I wouldn't be surprised for medical conferences to actually ease relatively sooner, with potentially the caveat that you've got to have documentation of having received vaccine before you can attend. So I wouldn't be shocked to see that happen even next fall, summer, maybe even late summer or fall. I think that's a possibility. But again, I'm looking at a crystal ball. For grandparents, I think that's always a personal decision at some level. And so, if I was a grandparent, I would say, I would want to get my 2 doses of vaccine and be at least a week out from my 2nd dose of vaccine before I'd consider getting exposed. But it is kind of weighing those risks and benefits. And so, it's an individual decision that's oftentimes complex. If you've got critical illness or end-of-life issues, maybe you're more willing to take the risk in that setting, just knowing that time may be limited and you don't necessarily want to wait until you have a full immune response.
Now, Dr. Anderson, did you say that the boost, you don't get the immunogenicity until the 2nd dose? Is there any benefit from the 1st dose?
Yeah, so this is actually being evaluated with all the vaccines. It may be that there's benefit even with the 1st dose of vaccine, but we think based off of what we're seeing from an antibody level that 2 doses are going to be needed in about a week after the 2nd dose. We're seeing really very good, very robust antibody responses by that time point. So if they work, which of course needs to be established, I think it's going to be likely that we'll see that as early as a week after the 2nd dose. And we may well see some impact even after the 1st dose. And that is being evaluated in these clinical trials, phase 3 clinical trials.
Thank you so much. Dr. Wax?
Yeah, well, I'd like to thank Dr. Anderson again for a wonderful and very timely presentation. Next slide. All of our webinars, including this one, are recorded and will be up on our website. This is the website page, and they're all available for listening at your convenience. Next slide. We'll continue our webinar series next week. At one point, we were planning to go to every other week, but given the 3rd wave now and the importance of continuing to push out critical information, we'll be continuing weekly, at least over the next few weeks. We really have the pleasure of having the president of the American Academy of Pediatrics, Dr. Sarah Goza, as our featured speaker next Wednesday, and she'll be talking about children and school in the context of COVID-19. That's November 4th at 3 p.m. Next slide. In subsequent weeks, we'll be having webinars on the 11th on risk communication, on a special webinar on a Friday. We usually have webinars on Wednesdays, but Friday, November 20th, and on testing and treatment of seasonal influenza during the COVID-19 pandemic. This will be also a critically important webinar. And we will be getting our kind of mini series on disinfectants with the inaugural webinar on December 9th about disinfection primer for healthcare those with who work at a healthcare facility. Next slide. All of our webinars, both past and in the near future, can be found on our webinar series prospectus, which is also available for download on our website. I'd like to thank everyone for attending today, and again,